Welcome to The Explainer. I am so incredibly excited to take you through today's topic. Today we're basically putting on our trench coats and stepping right into the role of the clinical detective. We're going to navigate one of the absolute most complex, high-stakes pathways in all of neurology, figuring out the exact culprit behind acute demyelinating syndromes. When the central nervous system is under attack, finding out who or what is doing the damage is a literal race against the clock. So grab your magnifying glass and let's get to work. Picture this scenario for a second. You're the attending physician down in the emergency department. A patient rolls in with rapid onset paraparesis, partial paralysis of both legs, and it's developed over just a few hours. They're losing sensation, their bladder function is compromised, the clock is ticking loud, and nervous tissue is actively dying. What is your absolute first move? How do you quickly distinguish between a surgical emergency and a really complex autoimmune attack?
All right, so here's our agenda to solve this case. 1. Urgent workup. 2. Fluids in blood. 3. Diagnostic criteria. 4. Signs on scans. 5. Treatment strategy. And 6. Prognosis and pearls. Let's dive in.
Section 1. Urgent workup. The scene of the crime.
Okay, so before we go hunting for exotic autoimmune suspects, we have to secure the scene of the crime. When it comes to the spinal cord, time is tissue. While we're dealing with suspected acute myelopathy, our immediate actions have to be incredibly precise. Step 1 is always, and I mean without exception, an MRI of the entire spinal cord. Why? Because we absolutely must rule out extraaxial compression. A tumor, an epidural abscess, or a hematoma compressing the cord. That requires urgent surgical intervention, not steroids. Now, once compression is ruled out, we move to step 2, a brain MRI. We're looking for dissemination in space. Are there lesions higher up? And finally, step 3 is the lumbar puncture, so we can collect cerebrospinal fluid for biochemical analysis.
If you map out the decision process, it forms a really brilliant algorithm. Right at the top, we confirm the myelopathy. Then, right in the middle, we hit that critical split. Is there a structural lesion compressing the cord? If yes, you get an urgent surgical evaluation. But if no, we proceed straight to the lumbar puncture for CSF analysis, checking for signs of inflammation like pleocytosis or an elevated IgG index. This is your mental roadmap for those chaotic first few hours in the ER.
Section 2. Fluids and blood. Dusting for prints.
So, we've ruled out physical compression. Now, it's time to dust the nervous system for biochemical fingerprints. We are hunting for the specific autoantibodies and cells, the culprit left behind. And what's really interesting here is the stark contrast between multiple sclerosis and neuromyelitis optica spectrum disorder, or NMOSD. We call this the rule of contrasts. An MS flare typically shows a pretty mild cellular response, usually less than 50 white blood cells, but it's highly positive for oligoclonal bands, or OCBs. We see those in 85 to 95% of cases. NMOSD? It looks completely different. It presents with much higher pleocytosis, often over 50 white blood cells, sometimes even neutrophils. But those OCBs? They're usually absent, negative in 70 to 85% of cases. It's a totally different biochemical fingerprint.
But hey, we can't just stop at the CSF. We need to look at systemic biomarkers in the blood too. In literally any patient presenting with severe myelitis, especially longitudinally extensive transverse myelitis, the kind that spans 3 or more vertebral segments, testing for AQP4 IgG and MOG IgG via cell-based assays is absolutely mandatory. These two specific antibodies have completely revolutionized how we diagnose demyelinating diseases. We're also going to run systemic screens for lupus, Sjogren's, and sarcoidosis alongside paraneoplastic panels. Why? Because sometimes the spinal cord is just collateral damage from a larger systemic issue.
Section 3. Diagnostic criteria. Naming the suspect.
We've gathered all our clinical and biochemical evidence. Now we use international consensus rules to formally name our suspect. Let's look closely at MOGAD, MOG antibody-associated disease. The strict A, B, and C requirements have to all be met to definitively diagnose it. First, criterion A, you need a core clinical demyelinating event, like optic neuritis or myelitis. Then, criterion B, a clear positive MOG IgG test. But pay attention to criterion C. This is absolutely vital. You must exclude better diagnoses, and that includes multiple sclerosis. MOGAD is its own distinct entity, and ensuring we don't accidentally misdiagnose it as MS is crucial for getting the treatment right later on.
And what about the others? Well, for NMSOD, if the patient is AQP4 antibody positive, the diagnosis is pretty swift.
You only need one core clinical characteristic, like that long spinal cord lesion we talked about. But if they're antibody negative, the rules get incredibly strict. You need evidence of dissemination in space and a very specific MRI findings. Oh, and here's a massive exam pearl regarding acute disseminated encephalomyelitis, or ADEM. To diagnose pediatric ADEM, the patient absolutely must have encephalopathy. Let me repeat that. If there's no altered mental status, it's not ADEM.
Section 4. Signs on scans. The mugshots.
So every single one of these syndromes leaves a highly specific visual calling card on the MRI. If you know what to look for, the scan will practically shout the diagnosis at you. This breakdown right here is your ultimate high-yield cheat sheet. MS favors short, peripheral spinal lesions and those classic periventricular Dawson fingers in the brain. NMOSD. It creates massive central spinal lesions spanning over 3 segments, and it loves attacking the area postrema in the brainstem, which, fun fact, is exactly why these patients often present with intractable hiccups. Meanwhile, MOGAD has a predilection for the lower cord, the conus medullaris, leaving fluffy brain lesions. And sarcoidosis, it leaves a classic trident sign in the cord and enlarged lymph nodes in the chest.
Let's really cement that visual memory. Think about looking at an axial view, a cross-section of the spinal cord. MOGAD specifically targets the gray matter. And since the spinal cord gray matter is shaped kind of like a butterfly or an H, MOGAD creates this striking, bright H sign on the MRI. Sarcoidosis, on the other hand, attacks the outer linings and the central canal. That creates 3 prongs of enhancement that look exactly like a pitchfork or a trident. If you see the H sign or the trident, well, your suspect list just narrowed down to exactly 1.
Section 5. Treatment Strategy. The Intervention.
Okay, we've named the suspect. Now we have to intervene. The goal here is rapid de-escalation to prevent permanent axonal damage. For an acute attack, we are bringing out the heavy artillery. First-line treatment is high-dose IV methylprednisone. We're talking 1,000 milligrams a day for 3 to 5 days, just aggressively trying to shut down the inflammation. But here's the critical nuance you need to know. If the patient has severe motor deficits, or if we strongly suspect NMOSD, we do not just sit back and wait to see if the steroids work. We move rapidly to plasma exchange, or PLEX. PLEX actually physically filters the destructive antibodies right out of the blood. The data is super clear on this. Early initiation of PLEX is a massive predictor of much better long-term functional outcomes.
Once the immediate fire's put out, we have to prevent the next attack. And honestly, the long-term strategies couldn't be more different from one another. For AQP4 positive NMSD, even one more attack can be totally devastating, so we use aggressive targeted monoclonal antibodies like eculizumab right out of the gate. For MOGAD, early relapses are super common if steroids are stopped too fast, so the standard of care is a prolonged, really slow oral steroid taper lasting 4 to 6 months. Meanwhile, MS requires its own very specific class of long-term disease-modifying therapies. In fact, giving MS drugs to an NMSD patient can actually make their disease worse, which is exactly why our detective work early on was so incredibly critical.
Section 6. Prognosis and pearls. Case closed.
So, what can we actually tell the patient about their future? The outcome of these acute demyelinating syndromes generally follows what we call the rule of thirds. Approximately 1/3 of patients will make a good, near-complete recovery. Another 1/3 will be left with a moderate disability, meaning they'll require some assistance or lifestyle modifications. And unfortunately, the final 1/3 will face severe, life-altering disability. It's a sobering statistic for sure, but it's exactly why our rapid, aggressive clinical detective work on day 1 matters so much.
Okay, I want to leave you with a massive clinical pearl regarding the temporal nadir. That's the time it takes for symptoms to reach their absolute worst. Listen closely. The speed of onset dictates your entire differential diagnosis. If the patient goes from totally normal to paralyzed in under 4 to 6 hours, it's almost certainly not autoimmune. You need to be thinking about a vascular spinal cord infarction. If the worsening happens over 4 hours to 21 days, that is the sweet spot for inflammatory myelitis. And if it's a slow, insidious decline taking more than 21 days, you need to shift your suspicion entirely away from acute inflammation and start hunting for a neoplasm or a metabolic issue.
And here is a really fascinating contrast to end our clinical analysis. When you bring an MS or an MSOD patient back for a follow-up MRI a few months later, you're almost always going to see permanent scars or black holes where the nervous tissue was permanently damaged. But MOGAD is uniquely different. Despite having these massive, fluffy-looking lesions during the acute attack, those T2 hyperintense lesions in MOGAD often resolve completely, leaving a remarkably clean MRI. It's really a testament to how differently these distinct immune responses interact with the body's tissues over time.
Which brings us to the future. I mean, think about it. Just a few decades ago, many of these syndromes were basically all lumped together under the broad umbrella of MS. Today, thanks to specific biomarkers, we know they are entirely distinct diseases requiring entirely different treatments. So I want to leave you with this thought. As our understanding of immunology accelerates and as brand new antibodies are discovered, how are our diagnostic algorithms going to change in the next 5 years? The clinical detective's work is never truly done. Thank you so much for joining me on this explainer. Keep your eyes sharp and keep investigating.